So we've covered a bit of it through other lectures, but I'll still try to, advancement in, we'll talk a bit about facet fractures, advancements in classification and treatment. So I'll start off with a case here of a 53-year-old construction worker who fell from 5 meters and was unstable hemodynamically and had a fast ultrasound, which was positive. He moved all of his limbs, numbness in his right hand, and was alert, was brought into the trauma bay. As you can see here on the, he had a unilateral facet fracture dislocation, and on the other side it was intact. Or the other side was, sorry, one side was dislocated, the other side was broken with a perching of the other side. But overall, it was intact at this point. And we'll go back to this with a few questions towards the end of the presentation. So unilateral facet dislocation is the most frequently missed cervical spine injury on plain x-rays. It's one of the reasons why we're moving more into CTs as part of our ATLS protocol and moving away from plain x-rays. It leads to about 25% subluxation on x-ray, and if it's a C5, C6, C6, C7, C7, T1 in a big guy, you won't be able to see them on the x-rays, versus a bilateral facet dislocation, which leads to about 50% subluxation on x-ray and is often associated with significant spinal cord injuries. The facet fractures usually involve the superior facet, and again can be more unilateral, can be unilateral or bilateral. And we've got to remember again that 75% of them are in the subaxial spine, with 17% of them at the C7-T1 junction, which makes sense between the mobile and semi-mobile spine, between the cervical and thoracic areas of the spine. And these are very, very, almost impossible to assess through a regular x-ray. You really got to look at it. I remember a case just as I came back from my fellowship of a guy that was discharged home with a normal x-ray and started walking up the steps. Was an elderly guy, and he had and as he was moving up the steps, was becoming weaker and weaker, and came back 6 hours back to the emergency room paraplegic because of a missed injury at this level. So x-ray, about the imaging. So x-rays are important, but I'm not going to mention them here because I think we all understand that in a trauma setting, the patients are going anyway for a total body CT, and it's essential to include the cervical spine and look at it in all three, in all three modalities, in the coronal, in the sagittal, and the axial plane. Malalignment of a subtle subluxation is critical. Facet fractures, you can see associated fractures of the pedicle of the lamina, which are important for the classification. MRIs are not usually taken in the trauma setting, but in patients that have a dislocation of an altered mental status, which we want to assess what's happening with the discs in the front, or patients that had a failed closed reduction before open reduction, looking for a disc herniation or any neurological deterioration, which is seen during reduction, an MRI is probably important both for medical legal issues to see if there's any kind of cord injury or any kind of other problems that we've missed on the CT scan. So the classical, the Alan Ferguson classification talked about the 7 different modalities of spine injury, and we're talking here about either distraction, or flexion, or distraction with compression, which will involve a facet fracture or facet dislocation. The extension type injuries will not usually involve such an injury, more of a spinous process. So the Alan Ferguson classification divides into 4 levels of fractures. We have a facet subluxation, a unilateral facet dislocation, which is stage 2. Stage 3 talks about bilateral facet dislocation, 50% displacement, and a complete dislocation of 100% displacement. You can imagine, as a dislocation, as we move down the stages, the chances of having a neurological injury are greater, of course. Using the subaxial cervical spine severity score as SLICS, you can definitely look at the, talking about the characteristics, and we discussed it yesterday, and definitely we'll either talk about a distraction or a translation kind of injury, which gives it a high point, 3 to 4 points in the score, and depending on the integrity of the discal ligamentous complex, wanting to determine what's happening, and of course regarding a neurological status, if the patient needs to go for urgent surgery or not. Moving into the AO spine classification, which is, I would say, probably the most advanced one, and again, one of the downsides of using the AO spine classification, it's multiple, I mean, you have so many different variants going on. It's very good for academic purposes, but I think it might be a little bit too cumbersome for discussion with the resident in the emergency room in the middle of the night with all the F1s, F2s, F3s, and the different modalities. But here, it actually helps us put things into order regarding the facet injury. So on number one, F1, it's just, I'd say it's probably a crack in a facet or a small fracture. As you can see here on the X-ray, on the picture, there's a small fracture in the facet, which might be even from a hyperextension or lateral rotation kind of crack, which we can see sometimes. They usually will come with either a fraction in the transversum in the foramen, or in other small cracks that we can see in the lamina or the spinous processes. At F2 would be a semi-unstable fracture, which would have would be a non-displaced, but the fracture size is larger than 1 centimeter and comprises more than 40% of the lateral mass. These are important because these are signs of a future displacement, which will not cause a spinal cord injury, but could entrap the nerve root exiting over here through the foramen. You can see it right over here. Or even if it looks in place, that's a little, I'd call it, a yellow flag telling us you got to be worried about a future problem going on. F3 is a floating lateral mass. We discussed it yesterday a bit talking about fractures both in the lamina and the pedicle. And these, of course, are highly unstable because the entire pillar, the lateral pillar of the spine is unstable, and this fracture can easily rotate. And usually I'd say if you get an F3 kind of, if you see an F3 kind of a facet fracture, it's very important to go and look at the disc. And most of these, if you do an MRI, you'll see a torn disc or an unstable disc, in which will change your classification and saying, oh, this is not a stable one. But this can actually save you from a future trouble of going in and trying to either get a neurological deficit or a radicular problem later on. And F4 is what we already know. These are the pathological subluxation or perch or dislocated facets, and the bilateral talking about both sides. Of course, if you keep on going on with the AO spine classification, it talks about the neurological status and the vertebral artery status, which are important to assess as part of any kind of cervical injury. How do we treat them? So the non-operative care is usually in a cervical orthosis, which for an external immobilization of 6 to 12 weeks, usually for non-displaced or no risk for displacement kind of fractures. These are easier ones to decide. These are the easy ones. The small cracks, you can probably put them into a soft collar after a couple of weeks once you made sure you don't have any other injuries going on, and they'll heal like any small fracture in the body. The other extreme are the surgical ones. It's easy for us to decide which ones have to go for surgery. If you see a bilateral unstable fracture, we know we're going to take him for surgery. We'll reduce him, take him back to the Gardner Wills, as we discussed before, and take him back to the operating room as quickly as possible. Patients that have a neurological compromise or even a deterioration as we're going on, we'll know that they're going on, and we'll take them quickly to the operating room. And here we'll either do a closed reduction with an alert patient or an open reduction, yes or no MRI prior to reduction. And I think, when we discussed before in the anterior posterior parts of it, or a combined approach, which I don't think we should go in the sense of time, we shouldn't go into reevaluating that point again. What about borderline fractures? And this is probably the challenging point, because what happens when you have a marginal unstable fracture, an F2, an F3? Do we go in and do we operate on them, or do we wait and discuss, and do we wait and see what happens with them? Some of these fractures are very, very easy to put 4 screws in or do an ACDF on them and send them home without worrying about what happens for the next 6 to 12 weeks, versus do we take a patient for an unnecessary surgery, right? Do no harm. So the literature is not yet conclusive about them, and I think it's a point to most for debate. And I've just brought a few papers that discuss the issue. So this is a literature review which came out in 2016 discussing the treatment of isolated cervical facet fractures as systematic. And you see quite a few people, Alex Vaquero on it, and probably the entire cervical trauma group which got together discussing that stuff. And when they went through all the papers, and it's quite an extensive, it's a nice paper to read, but after reading all of that together, given that both non-operative and operative treatments are commonly used, should we operate? There's insufficient evidence to allow a comparison between treatments based on the clinical outcome. So it's a beautiful paper telling us, discuss it with the patient, tell him what he wants, give him both options. I don't know which one is better. I cannot tell you which one is better, and discuss the different things. And of course, you can come and say, look, in our hands, this is better. In our hands, is that better? But you need to really get the patient's consent, because we do not know, we do not have a strong nail to put our hat on regarding the answer for these. Okay. So there's another paper which came out of, and this is a paper, Jens, this goes to you, in a previous work of yours with the evidence-based spine care journal, which was a great journal to have up here. And it talked about this systematic review focus. Is a unilateral facet dislocation, is surgery really the preferred option? And you have a nice group of people on top with Marcel Dvorak on the upper bit. And again, the conclusion is, when faced with a patient requesting treatment for recommendations for their acute unilateral facet dislocation, the surgeon can talk about the treatment failure, persistent pain, or logical status of non-operative. Ultimately, it will be the preference of the patient that will decide between these two treatment options. So anyone telling you, it repeats itself. So should we operate or should we not operate? I'm not sure yet. About doing anterior approaches, and this is from the group from this is from Belabaro's group over here in the Seattle, 8% failure rate of ACDF. So an anterior approach for these kind of treatments seems to be quite a safe thing. But it's only 36 patients, and it's a small and retrospective study. So I'm not sure if it's that great about that. And probably the best papers out this is a new paper out from 2019, discussing clinical outcomes of cervical facet fractures treated non-operatively with a heart collar or halo immobilization. So discussing, should we go back to conservative treatment? And it's an interesting paper because we're very good in putting implants into people. Definitely we have a strong bias by industry to put this stuff in. And this group comes together and discuss quite a few they talk about 80 patients and in talking about operative and non-operative cases. This is a table 4, which is probably the most important one in this paper, and talks about cases that were operative versus successful non-operative and failed. Where did we fail with the non-operative measure? And forgive me for diving into this pool, and if you look at the things that were important for them, one is the fracture size. The larger the fracture size, the chances of it failing a conservative treatment were greater. So if the fracture size is more than 1 centimeter, as the F2 AO classification, the chances of it are statistically significant, higher to go on and fail non-operative treatment. Then the amount of involvement of the lateral mass. Again, the larger the fracture, the more lateral mass that's been shattered, the larger case you need to go on and do surgery, the failure of the non-operative treatment, displacement, comminution, radiculopathy. Of course, all of these come together to help us, guide us which way to go. So in the conclusion of this study, I think patients that have a unilateral facet fracture should receive a trial of non-operative management. However, patients who weigh more than 100 kilograms, I'm not sure why they mentioned that there, but it could be in one of the sub-analysis, have comminuted fractures that have a large fracture outside of 1 centimeter size, should be educated on the risk of treatment failure. So I would say, if it comes to us, if a patient has a fracture that's larger than 1 centimeter with a major comminution of his lateral pillar, probably offering in small ACDF level would probably be helpful for him. Going back to our construction worker, so this is, again, 5 meter. He fell from 5 meters, unstable. He has a positive FAST in the trauma bay, which means bleeding to his stomach. He's got a torn spleen when they did a CT scan on him. He's moving all limbs, and he has numbness in his right hand, and he's alert. These are, again, his mid-sagittal views. Sagittals, what should we do now? And this probably goes to the questions to you guys. What should we do now? So he's an unstable. We can't take him. I mean, we can, one of the urgent surgery, MRI traction, or wait for patient stabilization. So again, he has a torn spleen. He's getting blood. He's unstable. Relatively, it's not an isolated injury. What should be our proper this next step? So he's unstable. So for the people that answered an MRI, it's a patient that's unstable is getting blood. Should he be in an MRI for half an hour? No, right? I would say that urgent surgery in an unstable patient, probably also not the best option. Interestingly, only 8% said traction, 46 wait for patient stabilization. Can we go back to my slides, please? And so if we're moving on, what happened? So we're back in our trauma bay, so we can put traction right over here. So we keep him in the trauma bay, he's getting his blood, he's being stabilized, and we're putting on the traction as we're going on. We put the Gardner wheels on, we start putting some moderate traction in consideration. You can already see how, maybe I'll use the laser pointer instead. We're talking here about a 5.6, which is hard. You see how hard it is to see on an x-ray where the 5.6 is? These are shoulder blades. This is a big construction. I mean, he's a worker. He has big shears. One shoulder is the other shoulder. And you can see we're almost back to neutral at this point. We're quite confident that we'll achieve, and we're putting the reduction. We don't go for a major. We do a slow reduction over here. He's not going to go for surgery in the next several hours because of his overall situation. We can take the benefit of the time and giving him the blood and the support, and he's being transferred to the ICU for stabilization. And we can probably, I think we put in 5 kilos, which is about, I'd say, about 15 pounds, 10, 15 pounds. We don't want to over-distract him. We don't want to cause a iatrogenic problem. He's totally alert. And we know that we can repeat the X-ray in several hours as he's becoming more stable, so we can take him to the operating room. So this is ICU cables all over him. This is 6 hours later. He's becoming more stable, and you can see how a slow and progressive reduction, he's reduced by this point, okay? So giving it the time, despite what we discussed before, in an unstable patient with a mild neurological problem, with slowly reducing the muscle tonus as he's becoming more relaxed, allowed us to reduce him without putting on a dramatic amount of weight on him, and we haven't lost time. So what do we do now? Okay, let's go back to our questions. So at this point, now he's reduced. Should we do an MRI? Should we go for surgery, an ACDF? Should we do a posterior approach? If anyone has anything else to do. So no change in his neurological status. He's becoming stable. Okay. So I think an MRI is a reasonable answer here. I think that at this point, our Gardner wheels are not MRI compatible, so I would not, he's still in traction, so we didn't go for an MRI on him. But I think at this point where we have a nice reduction, even if we have a bilateral win, I think an anterior approach is what we would opt for. Would anyone go posteriorly on this kind of a case? Sorry.
Yeah, I would say why not go posterior?
He has a spleen fracture, torn spleen. I'd say the general surgeons, at least by us, are very, very, if you're keeping the patient supine, and for some, we're much easier taking them for a surgery at this point versus putting him on his stomach with something torn in their abdomen, liver, spleen, be that. Right, the patient's issue, right. Patient. Right, and I've been discussing the C2, C3. I had a patient that they did a sternotomy on. She was like 120 kilo, about 5 feet tall, and they thought she had a pericardial effusion. So the cardiothoracics did a sternotomy, and then they said, oh, it wasn't a tamponade, it was just some pericardial effusion. So go put her on her stomach. You can't put her on her stomach for the next 6 weeks. So, we got to remember that the patients come in with complex problems. It's not usually an isolated problem. You got to deal with what you got. So doing a posterior approach at this point, you need to wait for 2 to 3 days at least, which is, I think it's a reasonable thing. The only point is, again, you don't want to keep into Dr. Chapman's point, you don't want to keep him in bed for 2 to 3 days with risk of PE. You want to get him out of bed as quickly as possible. So let's go back to the slides, please. And so this is in the operating room again. With the traction, you can see how it's almost like, why are we taking him for surgery? It just looks like a normal spine at this point, right? So it's we don't put grafts in, we put cages in. So, I mean, we don't have grafts. So I think discussing stability, I think, it's very, very simple ACDF for this guy. But I think the one thing, if we're talking about cages versus grafts, I'm not sure, I don't know enough about grafts to say, is there a biomechanical advantage in putting a PEEK or a metal kind of cage versus a piece of bone inside, just allowing you a little bit more support to the end plates in this kind of a situation? I am not sure. Anyway, he's out, he's home, this is 6 weeks after surgery, so everything, thank God, went well. I think after discussing, going through the slides, just to summarize, what would people here do? In a single facet fracture with no neurological compromise, in an isolated facet fracture, would you go for a collar or halo frame, anterior surgery, posterior surgery, or any wait and see? So I think it's a complex, it's not fair to put everything into a simplistic point. I think if he has no neurological compromise, if it's not a floating facet, if it doesn't reach that 1 centimeter fracture, or the F2 criteria of the AO spine classification, I think a collar is a reasonable initial option. And regarding anterior versus posterior surgery, I think it depends on what we see. If he's got a radicular pain, it's much easier to deal with that for a posterior approach, taking the pieces of bone out. Definitely if he doesn't have a disc herniation. But the anterior surgery for a torn disc is so easy. It's really the disc is totally shot, so it makes it very easy for us to discuss it. Okay, let's go. Switching back and forth. So just end by thanking you and welcoming you guys to come visit us in Jerusalem anytime you want. Be nice to have you guys over. Thank you.
Great. That was great how you had some questions of the audience, and some feedback also. Fire away, Alex.
So in your experience, what are the most common injury mechanisms for like a unilateral facet fracture, and does it rather happen in the old person with bad bone quality or the young person? Because I imagine if a young guy has such a fracture, it might be a huge trauma to cause it.
So usually, facet fractures are usually, an isolated facet fracture, usually younger patients. We're talking here, you see a lot of osteophyte fractures. So, you can, in elderly patients, but usually we're talking here about lateral flexion of the neck in an impingement. Don't forget, people don't always go forward. They can go sideways also with the head in a trauma kind of injury. So that's what we see that usually. You can see in it impinges and breaks that lateral, maybe a flexion, rotation kind of injury more than and then it depends how much energy went through. Most of the cases that we see are in high energy kind of scenario. You got to remember, but one very important thing to think about trauma modalities is that people at an older age are still doing risky behaviors. We get motorcycle accidents in the 50s and 60s. I had a guy who is 62-year-old that was doing paragliding in Albania, and just before he crashed into the ground, he lost consciousness for some reason, and he lost control, and he crashed into the ground, broke his spine. So, and then after we fixed him, he had to go get a pacemaker placed. So it's because it turns out he has sixth sinus syndrome, and so people are age is just a number, but it's not in the biology sense. So you got to, it's not anymore young or old. You can have a 75-year-old person driving around a Porsche, right, and doing crazy stuff, and okay.
So the stability versus instability assessment is so critical, and they happen very easily. Actually, we had just the other day one of our senior nurses, her son is a football player, he's 16 years old, strapping kid. He got hit in a very nondescript place that we actually have a video of it, and he had a floating lateral mass injury. We actually treated him non-surgically because he was totally aligned. Tell us again.
Collar or halo?
We put him into a collar, rigid collar, and he's been very compliant with that. He's very scared. He did not want a halo. We discussed that. And he stayed reduced. We got upright x-rays on him, got recumbent laterals, and he stayed
Nice.
very good so far. So one more time, we have an x-ray, we have a CT, we have an MRI. And everything looks pretty good on those. The patient's neurologically intact. Do you, in that acute setting, get a flexion distraction injury if the patient is awake or not to assess stability, or is that
No.
just a no-go?
I would just, I wouldn't take my chances at this point. I think, the patient's in a lot of pain, so we wouldn't get a real flexion extension on him. You know, like any kind of fracture, it hurts. So I'll just keep him in a collar and wait in 2 weeks out. I mean, I don't need to test the stability.
No.
I don't need to force it at that point. And in an older population, I'd be scared of the missed injury kind of thing, of what you've shown yesterday in ankylosing spine, which is a total different ballpark about the flexion extension.
Valuable insights. Thanks for sharing them.
Thank you.